Hello everyone. Today I'm going to discuss about the continuation of the last topic, which is the cerebral palsy. Today I'm going to discuss about the cerebral palsy assessment and also management in this topic. So in the assessment, we are going to discuss about the what are the subjective examination and also objective examinations. And we are going to discuss about the management, how we are going to handle the cerebral palsy patients. So here, first one is the subjective examinations. So in the assessment, if you see the assessment plan, so if any patients comes with the difficulties of the or maybe our cerebral palsy complications or cerebral palsy symptoms, so first we have to assess thoroughly. So according to the assessment, so we are going to diagnose the what type of cerebral palsy and also what are the complications and also what are the major goals and interventions we are going to perform for the according to the symptoms and also the signs. So in the subjective examinations, so first we have to check the history. We have to take the proper history from the patients. That is the subjective details such as the name and also age, sex, and also address. So name mainly for the their communicating purpose. We have to know the name and also age. We have to know the exact age because of we have to know the milestone development. So how is the milestone development? If we know the exact age, we can predict the what is the according to the how is the milestone development, is it normal or abnormal, we can predict according to the age group. And also we have to know the gender, are male or female. So because of some types of the cerebral palsy are more common in the male and also female. So especially in the last class we discussed about the most of the cerebral palsy cases are normally the more percentage will be in the male than the females. And also address for the communication purpose, so we have to know all the details. And so when did the mothers first notice the dysfunction? So we have to know the chief complaint. If the patient comes with a cerebral palsy, so what is the chief complaint? Chief complaint, is there any what are the difficulties of the patients? So is it because of the ambulation or maybe walking pattern, maybe posture, or maybe is a milestone development? So according to the age group, so we have to know so what are the major factors? Is it because of the disability or is completely dependent or independent? So we have to know. So during the assessment, we have to get the full information from the mother or maybe caregivers who are available with the patient. And also we have to know the siblings have the same type of the symptoms. We have to get the information about is the patients having if the if the any patient comes with the mother, so we have to know any other siblings having the same symptoms. So who are having some genetic defects, sometimes these symptoms may commonly seen in the siblings also. Maybe younger brother or maybe younger sister may having some genetic difficulties and abnormalities. So we have to know any symptoms related to cerebral palsy with the same patients to with the siblings. And also we have to get the full history of the patients. So this history is going to give especially for the complications of the pregnancy, delivery, the birth weight, gestations, any neonatal, perinatal difficulties, any feeding problems, and also other health related problems. Because of if we know about during the any complication, if we take the history, we are going to get the complete history of the prenatal, perinatal, and postnatal. And also how is the delivery? Is it the normal delivery, or is the cesarean surgery or delivery, or how is the baby weight? Is it the normal birth weight or the low birth weight or overweight? So if you know, we can predict the causative factors and also what could be the cost type of this a cerebral palsy. So we can easily predict according to the some historical informations. And also how is the gestations or any neonatal or perinatal difficulties, any feeding problems at the how is the baby birth, is it the how is the a score, a birth cry, Apgar score. So that means how is the breathing pattern in the child, the skin color, respirations. So all these things will come under the Apgar score we have to know. So these things we have to, if you get the full information, full history from the parents, so we can predict what are the causative factors and also what could be the causative factor for the cerebral palsy. And also we have to know the milestone development. What is the milestone development means? How is the development in the baby after the delivery? So according to the age group, so it should be development should be for example, in case of after delivery, the baby is going to recognize the mother. After the 1 month, the baby is going to recognize the mother, and social smile, and also neck control, and sitting posture, creeping, crawling, standing. So it will be according to the stages of according to the age. So these developments will take place. If any delayed in these developmental, so it indicates the delayed milestone development. So that's why we have to know so we'll discuss what are the normal development, and also what is abnormal development. So in the history, we have to take the prenatal history. So prenatal history, we have to know about the age of the mother. So we have to get the information from the mother. So because of who are having if the mother age is grows, for example, if the pregnancy, if the mother get above 40, who are get the pregnancy, so those people may chance to get some complications. It may leads to the a cerebral palsy. So that's why we have to know, is it the late pregnancies or early pregnancies, and also any history of the consanguinity marriage. Consanguinity means the blood relative. Blood relations means if the same family members, if they married each other. So because of the blood relations also sometimes may chance to get the abnormalities. So those people may chance to get the cerebral palsy. Especially, for example, same family members, the mother, mother's brother, son, or maybe mother, daughter, something, close relative family, sometimes in some customs and traditions, they are going to get married. So that's the reasons who are the close relatives, so may chance to get the cerebral palsy. And also any drugs taken during the pregnancies, in case of if the mother got any infections or any other complications, if they are painkillers or related to any pregnancy, avoidable drugs, so such as some antibiotics, some antiviral, some drugs are going to be interacted during the pregnancy. So the time should not take take the medications. So if it is emergency, so have to take the under the guidance of the physicians. So if they take improper medications, or the side effects of the drugs also may chance to get the cerebral palsy. So that's why we have to know any history of the drugs during the pregnancy, or any trauma or any stress during the pregnancies. Sometimes if any history of the fall down, or if any accident, are also may chance to get the injury to the baby as well as mother. And also any addiction such as alcohol and smoking. So we have to know the history of the mother. Is there any history of the alcoholism, and also smoking also may chance to give the effects to the baby, or fetal alcohol syndrome or smoking syndrome. So these are going to may chance to give the cerebral palsy. And also any history of the infections such as the torch infections. Torch means the toxoplasmosis, any other agents, rubella, or German measles, or cytomegalovirus, and herpes simplex. If any virus or any infection from these infections also may chance to get the cerebral palsy. Any history of the previous abortions, or stillborn, or deaths in the, so these are may chance to get the some may chance to get the cerebral palsy complications. So that's why we have to know, we have to take the history from the mother, any history of the abortions previously, or maybe any deaths after the birth also, or any multiple pregnancies. Sometimes who are get the more pregnancies or multiple, there is no gap between the one pregnancy to another pregnancy. So these type of problems may chance to get in the may chance to get the cerebral palsy. Coming to the perinatal is a history, so we have to know the perinatal history. So we have to know where is the place of the delivery. Is it the hospital, or is the home, or nursing center, or maybe sometimes maybe some a healthcare workers, or maybe is like a super specialty. So we have to know what is the place of the delivery, how is the accommodation, and also what are the facilities are there. So sometimes if any emergencies, so the equipments are available to the bench to give the facilities to the baby as well as the mother. So we have to know what is the place of the delivery, history of the preterm or postterm of the delivery. So is it the duration of the pregnancy, is it the preterm or postterm, any history of the asphyxia. So during the delivery, if any the child got any asphyxia or a difficulty in breathing, history of the labor. So is it the prolonged labor, or is there a fast labor, or pains? So how it happened? Is there any because of the injections, or any hormonal injection, any such as oxytocin? If there are some people may chance to take to oxytocin because of if the women may chance if the mother won't get any pregnancy or labor pains, so doctors are going to give the some hormonal injections. So how much the duration of the pregnancy, so these things we have to know. At least we can get some idea about the during the pregnancy or during the like a delivery time, what happened we can predict. And also type of the delivery. Is it a forceps delivery or vacuum delivery? Is it, for example, if the cesarean delivery means, so how they are going to be, it's not much problem as related to the asphyxia. Or maybe if the normal delivery, so if the mother birth canal, if the size is small or the baby size is bigger size, if the baby head is not coming properly, so sometimes have to do the forceps delivery. So the surgeon and doctors are going to use the forceps put into the birth canal. He's going to pull the baby come outside from the birth canal. Are sometimes going to use the vacuum delivery. They're going to put the vacuum to the baby head at the cervix at the birth canal opening. So because of the vacuum, it's going to push the baby head and also going to get the delivery. So if we can predict in case of the forceps, maybe if any compression or if any vacuum, if any abnormality, so also may chance to get the damage. And also coming to the presentation of the child, is it the breech presentation or in the normal presentation? Normally, in the normal positions, the head comes to at the birth canal first. So in the head comes, normally the baby deliver, so through the first head will come first. But in case of the abnormal, like a breech positions, the head is going to be tilted. First that comes to the legs are going to be comes forward. So in these conditions, may chance to get the so many complications who are having the breech positions. If the legs comes forward, so what happened if the body comes outside? So sometimes because of the prolonged duration of the pregnancy, the head is going to be come inside. So the body is going to come outside. So because of the during process, if the baby may chance to get the asphyxia, or maybe because of the swallowing of the amniotic fluid, or maybe meconium also may chance to get the swallow. So because of these things, may chance to get the like a difficulty in breathing. And also conditions of the mothers at the time of the delivery. So how is the mother's conditions? Is the stable or any emergency, or is there any increasing the blood pressure or increasing the like blood sugar levels, or any convulsions, any seizures, that means any fits or something. So we have to know any like if any complications related to the diabetes, related to the delivery. So we have to know, because of some type of the complications may give the baby injury also. That means injury to the baby may chance to get the cerebral palsy. And coming to the next one is the postnatal delivery. So we have to know about the delayed birth cry. So we have to know the birth cry. So how after the delivery, the baby cry is the normal or is it delayed? So who are having delayed birth cry, so may chance to get the like this delayed birth cry is due to because of the any abnormality or because of the decreasing the like oxygen supplies to the baby. So maybe we have to check the is any delayed birth cry is there or not. The weight of the child at the birth. So this will use the clear information about the baby. So if the low birth weight, we already discussed low birth weight, it may chance to get the cerebral palsy. So we can know the birth weight. History of the trauma of to the brain during the first 2 years of life. We have to know any history of the fall down, baby fall down, any shaken syndrome, or if the history of the any object fall on the baby. So sometimes we may chance to get these things. So during the growth time, so we have to know. And also any history of the neonatal meningitis. So any infection to the brain or any jaundice are related to the like any increasing the bilirubin levels, hypoglycemia, decreasing the sugar levels, and also next about the hydrocephalus, microcephaly. So these are the congenital abnormalities. Microcephaly means the brain is going to become the very small size. And hydrocephalus means it's going to be increasing the CSF accumulation in the ventricular system of the brain. So these things are acquired or maybe congenital also. So these things, if we know exactly, so we can predict the causative factor for the cerebral palsy. And also next one is we have to know the nutritional habits of the child. So such as any nutritional abnormalities in case of the malnutrition they also leads to the postnatal injuries, and also may chance to get the infections. It may give the cerebral palsy. Any feeding difficulties, sometimes who are having the delayed milestone, the baby cannot suck the breast milk. So sometimes, so we can predict, so is the delay in the like a breastfeed, like a sucking reflex. So these neonatal reflex we have to check after the delivery. So during the like a baby growth. So if we check the neonatal reflexes, if any abnormality or in case of the delayed milestone, or in case of like any injury of the brain tissues, also may chance to get the is a loss of the sucking reflex. So these things we can know the causative factors, and also we can know the is a cerebral palsy symptoms are there or not, we can easily find out. Any medical, surgical, or physiotherapy treatment taken before. So that means if any patients comes, so at the age of first year or second year, if the baby having the difficulty in walking, any muscle deformities, so we have to know, is there any previous medical history, surgical history, any physiotherapy treatments are taken or not. So that will give the, so any progression is there with the medical management or any surgical management. So if no progression, so what could be the best like treatment plans for the conditions. So we can easily think if we get the complete history from the mother and also caregivers. So what treatment was used? So in case of the medical treatment, what medication they use for the muscle tightness or maybe muscle weakness or any other abnormalities like such as like extrapyramidal involvement or maybe cerebellar involvement. So is there any surgical procedures in case of any like a muscle tightness conditions, or maybe in case of the ligament like any like deformities, so any corrections are there with any surgical treatment. So any treatment with the physiotherapy also, so how is the improvement with the physiotherapy, any stretching and also the positioning techniques and stretching, and also these things, any improvement is there or not. So we have to know before the patient comes to your clinic and also hospital. Was the treatment effective or not? So we have to know is it effective or not. What was the ability level of the child at the time? So what is the ability? So if you know the normal milestone development, and also we can predict so which one is the normal and which one is the abnormal. So we can easily compare the milestone development. And also what obstruct the child from the progress. So what is the child progression? Is there any restrictions or what are the obstructions in the progression of the child? We have to check. And also Apgar score also we have to check. Apgar score means at the delivery or after the delivery baby. So doctors are going to be, the pediatrician is going to be check the Apgar score. It's related to the birth cry and also respiratory rate and heart rate, pulse rate, skin color. So these things all are going to be around the 10 scores. So in between the total score will be, Apgar score will be 10. So out of 10, what is the score? So the normal score means should be is above the 8 is going to be the like a normal score. If it is comes the 6 and also 4, so depends upon the score, the severity will be different. And also sometimes the birth color is different. The cyanosis, they may chance to get because of the decrease in the blood circulations, may chance to get the cyanosis, or maybe birth cry delay, or maybe respiratory rate is going to be increased or decreased. So these things are going to be helpful to know the Apgar score. So these are the postnatal histories. So this is about the history taking, the prenatal history and also perinatal history and postnatal history. So coming to the observations, so here we have to observe the patients, we have to observe the behavior of the child. So this behavior, whether the child is alert, irritable, or fearful in the sessions or during the particular activities. So some children are going to be is a cerebral palsy or like a delayed milestone. So there the behavior is going to be a little bit different to the compared to the normal child. So is going to be, so if we have to check, is it alert or irritable or during the like sessions in particular activities. And also child become fatigued easily and not during the activity. So, and also sometimes the child is going to become fatigued or very tired. So, or is not during the activity. So we have to check without the activity also, is the patient is the person, the patient is the active or not, we have to check. So what motivate his actions, particularly situations, person or the special playing things. So if the baby is, the person is like a patient is around like 3 years or 4 years or 5 years. So according to the age group, how is going to respond with the playing activities. So if we have to check how is the behavior, is he like a cooperative with the therapist or not. So we have to check, is he going to be irritable or is going to be some people are going to be like a scary and also fearful. So we have to check, so how is the patient is communicating with others as well as the therapist, or we have to check, then only we can start our therapies to recover, means to rehabilitate, to bring back into the normal conditions. And also we have to check the communication of the child. So how is the communications? So how is the communication with the parents? So, and also whether child initiate or respond with the gestures, sounds, also hand or finger pointings, eye pointings, or use words and speech. So we have to know how is the communication with the family members. So how is with the parents. So is he communicating? So depends upon the involvement of the structures, the communication will be different. So in case of the involvement of the, like if it is involvement the cerebellum, or maybe we may chance to get the dysarthria, so difficulty in speaking. And also in case of the cortex involvement, they may chance to get the tightness, but the speech is going to be normal. In case of like a extrapyramidal systems, also may chance to get the like a difficulty in the speeches. So this we have to know where exactly having the involvement. Some children's having the only they have get the tightness or abnormality in the muscle tone, but the remaining all the functions IQ is going to be normal. But in case of the spastic one is going to be the normal. They are going to get the like musculoskeletal abnormalities, but the remaining IQ functions are going to be normal. So how is the communications we have to check with the parents as well as the therapist. And also other observations, we have to find out any involuntary movements, especially in case of the dystonia, etheroid type of the cerebral palsies may chance to get the involuntary movements such as hemibalismus, chorea, ethitosis, dystonia may chance to get. And also we have to check for the any deformities and contractures, especially spastic type of the cerebral palsies are going to get the more deformities and also contractures. Is there any scar may be present in any other like a because of the any surgical procedures, any previous history of the surgical procedures may chance to get the scars. So we have any injuries and we can have to find any scars. Tropic changes may also be maybe seen due to the poor positionings. So because of the poor positions, and may chance to get this these tropical changes, they maybe they chance to get the callus formations, and also because of the complete sitting position, maybe is the cross leg sitting positions. The lateral malleus is going to get the thickness. Maybe is the dorsal foot also may chance to get the callus formations because of the positioning, which areas are going to be more contact with the ground. So those areas are going to get the more like a tropical changes. Any postural fall, postural front means is a slouching posture, crouching postures, or leaning forward, or because of the flexion deformities. So the postural, how is the the trunk abnormalities or maybe chest wall deformities may chance. So we have to know where exactly having the problems. And also gait abnormalities. So how is the gait pattern? Is it scissoring gait or ataxic gait, shuffling gait? So what type of the gait is because of the foot drop gait, circumduction gait? So many different pathological gaits are there. So it depends upon the involvement of the muscle structures. If, for example, if the tightness of the hip abductors, so because of the tightness of the hip adductors, may chance to get the like a scissoring gait, or because of the weakness of the gluteus medius, and also may chance to get the Trendelenburg gait, or also called as the duck walking pattern gait, or in case of dorsalis in case of the dorsiflexor weakness in the foot muscles, dorsiflexor weakness may chance to get the foot drops gait. So these type of gaits we have to understand. In case of like a tightness of the gastrocnemius and soleus, flexion of the hip and knee flexors may leads to the like a crouching positions, or maybe is the slouching positions. So these things we have to identify, depends upon the involvement of the muscle groups. And also use of the external appliances. If the patient comes, we have to check. So is there any, the patient comes with external appliances such as any splint applications, any cast applications, or if the patient comes with any braces or not. So we have to identify. So these will we have to observe if the patient comes to the clinic. So how is the attention span? So what catches the child attention? So how is the attention? Is he concentrating or is he communicating properly? So how is the eye to eye contact? So all these things, and also is he communicating is a very attention with any objects, like any playing things, or if you say something, is he orientating with the patient, the therapist or not? So all these things we have to check. How much time the child attention is maintained on a particular things. So normally these like a cerebral palsy patients, IQ is going to be compared to, depends upon the type of the cerebral palsy. Sometimes it may decreasing the IQ in case of etheroid and also dystonic type of. So they are not going to concentrate on the particular things. If they concentrate also, it will be less time of the attention span. So we have to check. So how much the time span is their attention span? How does present assist him to maintain the attentions? So because of, if we know, So how much the attention span, then only while rehabilitating, while giving some special exercise techniques, how he's going to concentrate. So we can analyze, and also according to his attention span, we are going to concentrate with the patients with the toys and special exercise and special positions. So we can give to maintain the posture and also to avoid the other complications. So what distract the child? So for which things is distracting is because of the playing activities, or maybe because of the any edible materials, or maybe toys, or what are the distractions, or because of the any imbalance, or maybe other problems. How is going to be distract, and what distracting to the child? So we have to identify. Does child follow suggestion to move or promoting to act? So how he is going to be communicate with a therapist, or so the parents? So how is going to be follow the suggestions or commands? So we have to know. So if he follow the commands and suggestions, so we have to advise so according to his problem. So the patient of the position of the child. So which position does the child prefer to be? So this depends upon the a person to person will be depends upon the deformities, it depends upon the disability, the patient position will be altered. So can child get into the positions on his own or with help? So if the patient is comfortable in positions, how is going to be enter into the positions? How he can go to the relaxed positions? Is he own or independent or dependent, or is a semi-dependent? So we have to check with assistance, child make any effort to go to that positions, so or maybe symmetry of the child. So we have to check in actively or passively maintained. So how is the symmetry in the limbs? So in the abnormality, and also is he moving easily or not? So we have to check his active movement or passive movement. Have to check in the both how he's maintaining the positions. So we have to record, else we have to analyze. So if we maintain the positions actively or passively, so we can understand so what the having the difficulties. If involuntary movements present, then which position these movements are decreased or increased? So sometimes some initiating some if they start the any activities, sometimes they may chance to get the involuntary movements. In case of the ethetoid and dystonic type of the cerebral policies, if they initiate, if they try to hold any a toys or edibles, or if they try to talk or communicate, so abnormal movements, the involuntary movements are going to be occur. So because of these things, it's going to be altered the position of the body. So we have to observe. So according to this one, we can give our treatment plan if we understand his way of the position. The postural control and also alignments. So how much the parental support is giving. So that means the postural stabilization and also counter positioning all the postures. So we have to know the patient sitting position, standing positions, and also activities. If we know the how is posture alignment, so we can know so what are the abnormalities. So how what type of treatment is required. So that means if any any postural alignments, or with any postural correction devices, any splint, any orthotics, or we are going to be any a corset, any so we are going to prescribe according to the patient the postural abnormality. So we have to understand about the posture and also alignment. The proper and also equal weight bearing is there or not, we have to identify. If the child center of the gravity appears to be is unusually high, so resulting in the floating legs and also poor ability to raise the head against the gravity. So, and also fear of fall in a child due to the poor imbalance. So if we know the balance of the patient, the child, and also we can understand, so what the treatment he required, and also he needs the exactly what a positional controlling devices such as the orthotics is required to them. So we can analyze, and also we can refer which orthotic is needed for him. So use of the limbs and also hands. So how is the use of the limbs, the limb pattern in changing or going into the position as well as using them in a position. So how they are using their limbs, especially for the upper limbs and also lower limbs. So what is the attitude of the limbs? What is the positions? So is it any flexion deformities or any extension deformities, internal rotation or external rotations? So it depends upon the type of the muscles, like a weakness or tightness, it may chance to get the deformities. So in the last class we discussed, if you are having the a flexor deformities or spastities, so they are going to get the tightness or adduction movements and internal rotations and pronation of the forearm and flexion of the wrist joint. So this is the most commonly seen in the a spastic type of cerebral palsy. So we can find this type of the abnormalities who are having the spasticity. And also next one is we are going to see about the whether one or both hands are used, or the type of the grasp and also release. So how is the hand functioning, and also like a grip activities we have to record, and also according to that we can give the task oriented training. Accuracy of the reach and also hand actions. So how much of the accuracy is there, how is going to be handled, so how is his fine movements, so that means how he can hold the pens or keys or maybe any small things, how he's going to handle, how to check. So depends upon his hand activities, so we are going to assess the functional skills. Any involuntary movements, tremors, spasms, which interferes the action are present or not. So we have to check for this one is the any abnormal movements with any actions or any muscle spasms or any interferes with the patient activities, we have to found out. And also coming to the sensory aspects, so we have to check for the how is the vision and also hearing, touch, smell, and temperature in relevant to the task. So because of so if any abnormality, so sometimes it's going to be difficult to rehabilitate rehabilitate completely. So in those conditions, so who are having some abnormalities, or if any lacking of skills such as the hearings or any smell or touch, so that time our rehabilitation will be different. The techniques, exercise therapy techniques are going to be different according to the deficiency. Does the child enjoy particular sensations? Whether the child enjoy being moved or having the position changed. So we have to know if the patient sometimes who are having the severe like a cerebral serious severe percentage of cerebral palsy in case of ethetoid and dystonic type of cerebral palsy. So if we change the positions, they may chance to get the other abnormal movements, and also it won't be like a comfortable position sometime to the patients. So that's the reasons. So we have to check which positions they are enjoying and which positions they are in the getting difficulties. So according to the type of the cerebral palsy. And also form of the locomotions. So how is the child is carried? So is a dependent or independent or any walking aids? The walking aids also, what type of the walking aids? Is it a wheelchair or any crutches or any walker? So or maybe any splint. So what are the walking aids they're using? So we have to understand. So according to that, we are going to start our a treatment plan. So use any wheelchair or walking aids, which daily activities motivate the child, roll, creep, crawl, and also bottom shuffle or walk. So according to this one, how they are going to be do the active movements with the walking abilities. So and also walking aids. So we have to check. And also next one is how to check for the deformities. So what type of deformity they have. So is there any case of the deformities, any body parts, so which remains in the particular positions in all the postures, so in the movement and also in the movement. So it is called the deformities. So especially who are having the upper motor neuron type of the lesions, so most commonly they may chance to get the spasticity. In those conditions, they are going to get the shoulder protraction and retractions. The shoulders are going to be the protractions or maybe retractions, or maybe it's going to be scapula is going to be protraction, or maybe retractions is going to be, and is going to be internal rotation, adductions, and also elbow flexion, forearm pronations, wrist and fingers flexions are going to be. In this position, most of the patients who are having the spastic type of cerebral palsy. And also in the lower limb also is going to be the semi-flexion of the hip, internal rotations, adductions, and also semi-knee flexion, ankle plantar flexion, foot pronation and supination, toes flexion deformities. So because of the tightness of the iliopsoas in the hip joint and also hamstring in the knee joint, and also tightness of the gastrosoleus, it may lead to the plantar flexion. So these are the common deformities we can find who are having the spastic type of cerebral palsy. So in case of ethetoid dystonic postures, so these are going to be such as the total flexion or extension they may chance to get. And also next one is the wind stripped deformity of the hip. So here is going to be one hip is going to be flexed, abduction, and also externally rotated. The other hip is going to be flexed and also is adducted and internally rotated. So this is going to be, and in the danger of the posterior dislocation, who already having this is the flexion and also adduction internal rotation. So those people may chance to get the posterior dislocation of the hip joint. So these deformities are most commonly seen in the cerebral palsy patients. And coming to the higher cognitive functions. So higher cognitive functions. So these cognitive functions, so we have to know how is these cognitive functions. So that means is how is the higher mental functions such as the is memory and speech, language, and also attention, calculation, judgment. So all these things we have to calculate. So because of if we know, so we can understand these IQ levels. So the patient's IQ levels. So this one is the patient is drowsy or lethargic. So how is the response? So and also is he alert or consciousness, and also decrease in the intellectual functions or mental retardations. So it's going to be how if we check the IQ levels, that means the calculations and judgment and also memory. So these things are going to we are going to easily predict the higher mental functions. So if the one child comes with the he cannot give the communication properly, he cannot express properly, but they are going to understand, they are going to give the show the answers in the gestures in different direct in the different manner, but their understanding is going to be high. Maybe sometimes their communication is going to be less. So we have to analyze properly. So according to the his cognitions, so we can predict so how much the improvement it will be. And also who are having this cerebral may chance to get the poor memory and poor attentions, comprehensions, and also speech are going to be also poor speech, comprehension, and also language. So if you know exactly, but in case of the a cerebral palsy spastic type, so the speech and also language is going to be not much affected compared to other type of the cerebral palsies. We have to check for the cranial nerve integrity. Cranial nerve integrity also very important. So in case of the strabismus or squint, so we can know it may be because of the oculomotor nerve. That is the third cranial nerve. So it may also involve. So if we identify the involvement of the a strabismus, so we can think we have to check for the other cranial nerves is there involved or not. So in case of the any visual defects, so its visual defects are related to the optic nerve. So optic nerve is going to be the olfactory, and optic is going to be second cranial nerves. Auditory nerve is going to be hearing and also about the auditory functions, especially for the eighth cranial nerves. And also feeding and swallowing problems, especially the lower cranial nerves. Lower cranial nerves is that hypoglossal and also glossopharyngeal. So these are related to the throat muscles and also swallowing and also feeding difficulties may chance to get if you have having any lower cranial nerve injuries. And also special senses, we have to check for the special senses. So these are going to be the visual, auditory defects. So we have to check for the visual and auditory defects. Tactile and vestibular hyposensitivity and also hypersensitivity. So how is the a tactile position as a touch and also vibration sensations and also vestibular hyposensitivity. So how is the position sense? So and these things we have to check in while assessing the patient. Coming to the examinations. So on examinations, first one is the sensory assessment. And sensory assessment, so it is difficult to assess the sensation in the babies and also young children with the severe multiple impairments. So it's not suitable for all the patients who are having the difficulties related to the who are having the multiple impairments. If any hearing or visual or psychological abnormalities are present, then assessment done by the specialist is required. So for example, in case of the vision problem, so if the patient comes to the clinic or in the hospital, in the rehabilitation center, so we are not going to be handle single person. We are not cannot handle one person. So we're having the vision problem. So we have to take from the guidance. We have to take the help from who are the specialist in the vision and also hearing and also psychological, a psychology, a counselor. So all these things are special educators. So this is a group of the teams have to involve while in the exam, while during the examinations. And also have to check for the motor integrity. So especially for the abnormalities of the tone. So is which type of the tone? Is it the muscle tone? Is hypertonicity or hypotonicity? Or is it dystonia? So what type of the tone is there? Or is a flaccidity? Or in case of the rigidity? So what type of the muscle tone is there? We have to check with the passive movement. So if we do the passive movement, so we can understand the muscle tone. Or if we palpate the muscle, the tone we can easily understand is that the hypertonicity or hypotonicity. Or is that if you do the passive movement, If the rigidity is there, so the tightness is going to throughout the rigidity. So different type of the rigidity we are going to found. Is it the cogwheel type of the rigidity, lead pipe rigidity? So depends upon the movement we are going to identify the muscle tone. And also in case of the muscular weakness, so we have to identify the muscular weakness. So how much if the patient is communicating properly, is your command is following the therapist command means, so we have to check the manual muscle testing. So MMT, manual muscle testing, is a help to check the muscle strength. So that is the grade 1 to grade 5. So then Oxford scaling grading scale is there. So we can use for this scale to assess the muscle strength. And also loss of the voluntary control. So if we give any task, so how the voluntary control is there? Are they able to hold the object or not? Are they able to do if we give any task? So how is the voluntary control? So is going to be like a handle is independently, or if any abnormality during the voluntary movement. So we have to identify during the voluntary examinations. Decrease the coordinations. So they may chance to get the coordination is going to be decreased. So what are the difficulties they have? What type of the coordination, incoordination is there? So we have to find out how is the like a dysmetria or dysbeudocokinesia. So what are the related to the coordinations? Maybe in the next class we'll discuss about the coordinations, and also what are the exercise coordination exercises. So we'll discuss in the next class. So there we can discuss detail about the coordination. And also we have to check for the reflex integrity. So check for the reflexes. So how is the abnormal DTR? So deep tendon reflex have to check is exaggerated. Normally these reflex are going to be exaggerated in the spastic type of the cerebral palsy. In case of the athetide one, the reflex are going to be is the normal or is diminished. So abnormal superficial reflexes. So is going to be superficial also reflex is going to be abnormal. Abnormal primitive reflexes may be persistent. So is atonic neck reflexes, extensor thrust, and a gallant reflex may chance to get. So these are going to be fun. So we have to find what are the reflex are abnormal. So we have to record it while assessing the patient. And also have to check for the ROM flexibility. So which joints having the restrictor of the joint range of motions, especially you are having the deformities. So those joints are going to be restricts of the joint movements. So we have to check for is it restriction because of the muscle tightness or because of the any joint structures. So is it because the tightness or contracture in the hips? So is this adductor, hip adductors, and also hamstring and calves are very tight. So these are the most common tightness are the spastic muscles. So because of the tightness of contractures of these muscles, so may chance to get the decreasing the movement, and also it may use the less flexibilities. And also we have to check for the is anthropometric measurements. So these anthropometric measurements such as the height or length of the decreased. So is going to be height of the patients. So and also is going to be growth retardation who are having the cerebral palsy. So may chance to get the growth retardations. So we have to check for the height of the patients. So according to we have to take the history also. So how is the development of the height? Normally how much should be there in the birth time. So and also we have to check for the weight. So this also going to be decreased. So this also going to be thin or lean, or maybe sometimes you may chance to get the obese. So if they're completely bedridden, so depends upon the severity. The patient don't have any other activities, is continually on the bedridden on the bed, so may chance to get the obese. And we have to check for the head circumference. In case of the microcephaly and also the growth retardations, so is may chance to get the head size is going to be decreased. But in case of hydrocephalus, the head size is going to be increased. So because of the accumulation of the CSF in the ventricular system, the head size is going to be bigger size. So we have to check for the height, weight, and the head circumference. So these things are very important while assessing the cerebral palsy patient. So these are going to be at the height of the baby. So until the 24 to 36 months of age, the length of the recumbency is measured using the infantometer. So after the age of the 2 years, the standing height is recorded by the stadiometers. So these things we have to know about the height of the patient. So the baby. So at the birth, the weight is normal height. The weight is going to be the 3.5 kilo. So that means around the 7 pounds. So it's around 3 to 6 months. The age is according to this 3 to 6 months. So it's going to be increasing the age in the months is going to be plus or minus the 9 kgs. So it's going to be increasing, the pounds are going to be 11. So according to the age, so it's going to up to the 1 year, it should be is the like a 4 times to the, if you see the age, this growth of the like a height of the weight of the patient, the initial after delivery, the first 1 week is going to, the weight of the baby is going to be less weight, is going to decrease the weight because of the loss of the water content from the baby. But after 3 months, the weight should be double. So it's going to be increasing the, after 4th month of the baby, is the height weight is going to be increased double. So after the 1 year, it should be triple. So that much of increasing is there normally. So if the baby is not getting the increasing the height, or if the baby is like overweight, you can easily understand. So according to the weight or weight chart. So coming to the, if the, so the height should be, so this is going to be the weight, kg and pounds. So these are also going to be according to the age group. So is going to be altered, this height and weight. And also head circumference. So this head circumference is going to be at the birth time should be the 35 centimeters. So if it goes, so it's going to be increasing the, after the first year, it should be increasing the 10 centimeters from the normal. So according to this head circumference, we are going to identify, is it microcephaly or is the hydrocephalus. So in the hydrocephalus conditions, so the head size is going to be increased. So we can easily predict, for example, if the age of the 1 year, it should be 45 centimeters. So if it is less than, if it is there in the same 35 centimeters, so it indicates the, there is no development. So it indicates the microcephaly. So if it reached to the 60 centimeters at the age of the 1 year, so it indicating the head size is bigger size. So it may be the hydrocephalus. So that is the reasons. So here we have to use the measurement tape and also have to check for the head circumference. So this tape is used to measure the occipitofrontal head circumference from the external occipital protuberance to the glabella. So from here, so we have to check from the up to here. So have to check. So this is going to be gives clear information about the head circumference size. So how the developments and also milestone developments. So if we know the normal milestone development, so we can understand, so where they're having the abnormality, easily we can recognize. So this I summarize here. So this actually is a very big, this also another big topic, but here I summarize. So here I mentioned is the, according to the age. So first age is going to be the 4th month to 6th week, sorry, 4th to 6th week. So that means after the 1 month, the baby is going to be the social smile. So social smile means the baby can recognize the mother and also can bring a smile to the mother. So social smile is there within the 1 month to like 1.5 months. So after 3 months, the baby can hold the neck. So head is going to be holding. So some children, and also after the any head injury or in case of any like a cerebral palsy symptoms, after 1 year also the baby cannot hold the head and neck. If you hold the baby head is going to be forward and sideways, cannot hold. Normal is going to be the 3rd month. So if they're having difficulties, so the mother has to understand about these developments. So if they recognize easily immediately, so if we start the therapies, so we can give the best recovery to them. We can bring back them into the normal life. Otherwise, if they're recognizing delay or late recognition, also the treatment also delay, it may give the difficulty getting the recovery. So that's why, so each mother has to, our family members has to understand about this milestone development. What is the normal development and what is the abnormal development? Normally at the age of the 6th month, so the baby can sit without support. So if the baby sometimes, it may, if the delay means the 1 month or 2 months means, it's okay, it's a considerable. But if after 1 year also the baby cannot sit, cannot walking, that means cannot sit without support means, so we have to think. So that means the baby having the delayed milestone. And also 7th month, sit without support. So the baby can, with the 6th month, the baby can with support. And also the baby 7th month, sit without support. So 5th to 6th month reaches out for the bright objects and also get it. So they can try to hold the bright objects and also they attract the bright objects. So that's the reason if we give shows any toys, the baby is going to attract it towards the toys and also bright colors. And also 6 to 7 months is going to be transfer the object from one hand to the others. So if we give any playing activities, they can hold with one hand and also they can shift from one hand to the other hand. So these are the normal responses. So if the baby is not getting this like a neck hold, no neck holding, and also if the baby is not concentrating, not sitting means, so we can think, okay, the baby having some like a delayed milestone. So immediately if we take to the like a concerned people, like a rehabilitation therapist, also physicians, so they are going to recognize the what is the problems. So according to the problems, if we start the therapies and treatments, so as soon as possible, we are going to improve their functional activities. So if you see here, so it's going to be 6 to 7 months. The starting is a imitating cough. So they're going to be imitating what we are going to do sometimes. And also 8 to 10 months, the baby can crawl, and also the baby can creep. So at this 8 to 10 months. So after this 10 to 11 months is going to be creeps, and 9 months is going to be the standing holding furnitures. So they are going to standing and also holding the furnitures with the holding support of the any like a walkers, the baby can standing. 12 months, the walks holding furniture. So that means if you give any tricycle or any like a triboard or this like a walking cycle, so they can walk holding with these walkers. And also this 10 to 11 months, so stands without support. 13 months walk without much support, and also 12 months says one word with the imitate in the with the meanings, and 13 months says three words with the meanings. 15 to 18 months joins 2 to 3 words in the sentence. So these are the like a basics of the like a milestone development about the motor activities and also language. So if you see here, normally they are going to say the says one at 1 year, so they are going to be like a says one like a one word. So there's going to be ma, ama, papa, mama. So these type of words that they are going to use at the age of 12th month. So that's the 1 year. So they're going to, after the near to the 1.5 year, they're going to join the 2 to 3 words in the sentence. So these are the some development, and also this is going to be like a communications and also language skills and motor functions is going to be developed. So if these are the normal development. So if any abnormality, if any patient comes to clinic after 1 year also, if the baby cannot hold the like a neck holding, if baby cannot sit, or if the baby cannot, or like a no social smile, not recognizing the bright objects. So these are all are going to be is abnormal like a milestone or delayed milestone development. So it indicates the cerebral palsy, or maybe is there any other autism, or maybe we have to differentially diagnose, or maybe Down syndrome. So who are having like this type of complications, we have to differentially diagnose properly. So we have to diagnose exactly which one is the cerebral palsy, or which one is other related complications such as the Down syndrome or autism, or we have to differentially diagnose properly. So coming to the, in case of the, in other milestone developments, at the 13th month, the feed self with spoon. So there, the baby is going to try to feed like without support, so with a spoon. And as 15 to 18 months, the baby is going to get the like state the climbs. 15 to 8 months, the baby takes the shoes and also socks off. So they're going to try to put the takes the shoes and also socks off. 12th months, put the shoes and socks on, and also takes some clothes off. 3 to 4 years, dress self fully. 2 years, the baby by dry by day, and also dry by night. And 3 years, and going to be no full names, and also is a male or female, and also rides the bicycle or tricycle at the age of the 3 years. So these are the normal development. So if any abnormality in the development, so we have to found where they're having the problems. So if the sitting problem or standing problem or speech or language or attention span, so where they're having the complications. So according to the patients, so what type of the cerebral palsy we recognize, so we are going to train properly, so according to the patient conditions. And also we have to check for the joint range of motions. So have to check for the active movements as well as the passive movements. So here is going to be, we have to check for the active head and trunk flexions, extension, rotation observed during the head raise in the prone, supine, sitting, and also standing developmental channels. So we have to check for the, how is the positions, how is the active movements of the baby. So in the supine positions, what movements are there, what range of movements are there, how the baby is moving the limbs, and also we have to check. And also we have to do the active shoulder elevations, abduction, rotations, flexions. So these things the baby cannot, if you say it, sometimes the baby cannot follow. So we have to give some toys. If you put some toys above his levels, he's try to hold the toys. he or she, the baby can try to catch the object, or if you away from the any, like if you put any object away from the baby, so the baby can do the try to hold the. So this is abduction. This is the, if you put overhead activities, it shows the flexions, or backside they're going to be extension, are different directions. So we can understand. So it depends upon the position of the activities. So we can know the what is the active movements. And also after that, we have to do the passive movement. So we have to know the where is the like a restriction. Is it the joint, or is it because of the muscle, or because of the deformities? So we can easily do the after active movements. We have to do test in the passive movements. So next one is we have to active elbow flexion extension observed during the child reach parts of the body or toys. So if we give the toys or any other objects, the baby is going to be try to hold. We can see the flexion or extension or rotation movements. And also active wrist and also hand movements will be observed during the functional developments. Active hip flexion and extension will be observed during all the functions. Active knee flexion extension seen in the active flexion extensions. Also, foot movements are also checked during the functional development. So if we give the baby activities, any playing activities, we can understand where they're having the restriction and also where they're having the limitation of the movements. So we can check through the different type of the like activities. Coming to the postures, so we have to check for the postures, any abnormality in the spinal deformities. Is there any scoliosis or kyphosis or lordosis, or maybe because of the knock knees, flexion deformities, inverted flat foots are commonly seen. So these things we have to identify. So we can easily find who are having like a bedridden conditions. So they may chance to get the kyphoscoliosis, and then especially in the knock knees may chance to get in case of scissoring gait. Flexion deformities we can see because of the tightness of the hamstrings and also iliopsoas muscles. Next one is we have to check for the balance and gait examinations. So this is going to be the dynamic and also static balance. How to check balance severely affected with the ethetoid and also ataxic CP. So who are having the extrapyramidal involvement as well as the cerebellum involvement. So those people are going to get the loss of the balance and also effects on the gait. Independent walking is rarely achieved by the spastic, quadriplegic, or etheric CPs. Few diplegic CPs can walk with aids. Hemiplegic CP can achieve the independent walking. So who are having the ethetoid and also quadriplegic, so difficult to reach to the or achieve the walking patterns. So it's a very difficult to like manage the walking patterns. So but in the spastic type of hemiplegia, so they will get the independent walking. So only thing is if they're having limitations, so according to those limitations, if we give therapies and also corrections, so we can improve their functional levels. And also bowel and bladder involvement. If the child is able to communicate and understand, training can be helpful. So sometimes in ethetoid and also dystonic type, so the baby cannot communicate properly. So they may chance to get the urinary incontinence and also fecal incontinence. So in profound MR, mental retardation and those unable to communicate have dependent functions. So they have to depend on the parents. So everything is going to be like depends on the parents because they are not communicable. So they cannot understand. So if they get any incontinence or in the fecal incontinence and also urinary incontinence. So coming to the functional capacity, so it varies from complete independence to the complete dependence. So this is a person to person vary, depends on the type of cerebral palsy. So we have to check. So how much the dependency, how much the independency. So that is about the assessment of the cerebral palsies. So we are going to discuss in the next class. So we are going to discuss about the how is the educations, how we are going to handle, how to promote and also about the family educations, handling and also care, promote infant and parent interactions. So how we are going to improve the skills in the who are having the cerebral palsy symptoms. So all these things we are going to discuss in the next class. Hope you understand clearly. If you have any doubts and also send me message, I'll clarify your doubts. Thank you very much. See you in the next class.